also? Okay. So I'm going to hit record.
Recording in progress.
And I wanted to thank all the work that Caleb and also Carrie have done on this, and also all the work that Andre and Erin did. Also, and I know there was people that helped them. I know that Jen helped them, and I can't remember the name of the other gal who helped them a lot in preparing the presentation. And I just want to say thank you. They did such an awesome job. And now we just need to get it out to everybody. It was so clear and easy to understand. But if people have questions afterwards, we'll be glad to answer them. So let's go ahead and get started, okay?
Vicki Lowe, Chair of the Universal Healthcare Commission, will now call the meeting to order.
All right, thank you, Mandy. Thank you, welcome commission members and members of the public. It is now 2:01 and we're starting the meeting a minute early. So we'll call the August 10th meeting to order. And this is our 13th meeting of the Universal Healthcare Commission. I'd like to start by giving a land acknowledgement. And just like to acknowledge that all of the lands that we live on across these United States, and especially here in Washington State, are Indigenous lands that belong to our Indigenous ancestors. And we just want to thank them for the care and their stewardship of the lands and the waters since time immemorial, and just remember all that was given up by these people in order for us to have what we have today. So thank you for being here. And again, a warm welcome to everyone joining us today. I see lots of members of the public. So let's start with an overview of the agenda, doing the welcome and call to order. We have 60 minutes set aside for public comments. We set aside 60 minutes for a presentation from the Washington Health Trust about Senate Bill 5335 that was introduced, and we'll be able to think more about what is in that bill and how that aligns with the work that we have moving forward. Next, we have public comments. The public comments that we have received since our last meeting can be found under the 3rd tab in your commission book. And we did receive quite a few. I think there was more than 30. So thank you for those of you who were able to comment. So Mandy, will you please start with the names of the individuals who have signed up for public comment?
I will, and I apologize if I pronounce anybody's name wrong. Mike Wayrush.
Okay, so I'm Micah Wyrock, and I've worked for over 35 years in nonprofit management, specifically generating revenue. And I'm going to address rural access to healthcare, such as in my county, Cowlitz, which has about 100,000 people. We're increasingly having difficulty accessing healthcare. When my father was dying 2 years ago, I couldn't find palliative care. My father had dementia and had difficulty going anywhere. Finally, with hospice, we were able to receive care, but that hospice facility has since then significantly reduced their presence in our community. With my mother, the rheumatologist recently left Cowlitz County, and many elderly and other people are having to spend a whole afternoon driving and attending to appointments when many of these people are not healthy. I suggest that the commission look at ways to use financial incentives and in order to bring providers to our community, at least on a part-time basis, if not full-time. Thank you very much, commissioners, for your time and for listening to me today.
Thank you. I'll move on to the next person on the list. Lisa Gaynor. Lisa Gaynor.
Yes, hello, that is me.
Okay.
Hi, I am a constituent of Cowlitz County. I am a widow and I am in between health services right now due to my employer doesn't provide insurance, and I am a widow, and I have had a very hard time um, understanding the insurance coverage and getting something that will truly work with me and for me. And my daughter also has had a situation where she has had to purchase insurance also. And we were able to find affordable plans, but the confusion began with once you pick a plan that you can afford, finding providers that actually are taking new patients, finding the coverage that you actually signed up for, which is a lot different once you have that coverage than what was described in the initial information. And just having something that most people take for granted, which is easy, good coverage. All you do is make a call. Maybe there's a small copay and you move on. I just want real coverage that we can all afford. Thank you.
Thank you. Mason? I just see the name Mason.
Can you hear me?
Yes.
Yes. Hey there. Yep, I'm Mason. I just want to say, healthcare would have meant a lot to me growing up. My family really didn't have money to pay for medication just to help us with our seizures, and that really affected us in school. And it'll probably affect my children too. And having something to just help out would mean a lot to just me and my family. I really hope this goes through. And yeah, I just want to thank you for your time. That's all I have to say on this matter.
Thank you. Mohammed, I'll circle back around to you.
Thank you. No, I just wanted to thank those who have taken the effort to submit their public comments. Just I wanted to add my story actually to just basically remind my fellow commissioners and everybody else. The inaccessibility of our health insurance right now is really hurting a lot of people. My story, like I'm the deputy director of a small non-profit organization. We provide healthcare insurance to our employees. And right now, for the last 2 years, I've been paid half my paycheck just to cover my 4 children and my wife and myself. So, I mean, if it's that expensive to me, I can only imagine what it's doing to, other Washingtonians. So I just wanted to add my voice to that, to the comments. Thank you.
Thank you. And I see Roxanne Thayer has raised her hand.
Hello, can you hear me?
I can, thank you.
Thank you. I'm calling to let you know a few things that are happening out here in the field in Washington State. One is that the Kitsap County Board of Health has declared just last month, July 2023, a healthcare crisis in Kitsap County. That's due to several reasons. One, CHI Franciscan takeovers and shutdowns of medical facilities and hospitals in that county. Same thing is happening in Eastern Washington. And then the other thing is the vast amount of junk insurance plans that several people have referred to. For instance, Molina is not accepted in Pierce County. My daughter has to go from Tacoma to Sequim to see a dermatologist who will accept her insurance. There are so many junk insurance plans out there that have been put forward as a step towards universal health care. It's not helping. We need to move to universal health care and then make the steps to get there with having already made that commitment. And then finally, it is essential to the people in Washington State to have healthcare access, and healthcare access that is not faith-based. And finally, the Universal Healthcare Work Group and the Washington Health Trust both showed beyond a shadow of a doubt that moving to single payer universal health care, Medicare for all, would save the state and the citizens of the state billions of dollars. Thank you.
Thank you. And that's everyone that I show for public comments. I'll turn it over back to you, Vicki. Chair Vicki Lowe.
So I'm just going to pass it off. We're excited. We've got set aside time today to hear from Andrew Stackhouse and Erin Georgian, is that right? From the whole Washington, to give a presentation on the Washington Health Trust bill. So Andre, Erin, are you ready?
Thank you all. I'm ready to kick it off. So I just want to start by thanking the commission for, perfect. Yeah, I want to thank the commission for having us today, giving us the opportunity to really dive into the details of Senate Bill 5335. Also a big thanks to the Senators Cleveland and Hasagawa for helping arrange this meeting. We're really looking forward to starting the conversation on this. We hope it's an ongoing and collaborative one. Next slide. And just a little note, these slides were submitted on the 2nd. We're presenting here on the 10th, but for the latest version of this material, as well as any other supplemental materials, you can go to wholewashington.org/UHCC-presentation. We hope to have some nice stuff up there in the coming days. Next slide. So just to introduce ourselves a little bit before we dive into all the policy stuff, my name is Andre Stackhouse. I'm the executive director of Whole Washington. My background is in information science, and I've worked in the tech industry at small startups like Code.org, as well as big companies like Microsoft. And my political background is mostly in healthcare stuff. I've represented the Democratic Party at the state and national conventions. I co-founded a national group called Medicare for All Everywhere, which is sort of intended to develop state movements like this across the country. And I led the last Whole Washington initiative campaign, I-1471. But I'm really fortunate to be joined by Erin today, who's one of our most prolific policy consultants on the Health Trust, who's going to really back me up with your really, really tough questions that I know are coming.
My name is Erin Georgian, and I am a technical communications and design specialist by trade. I work supporting community-based health organizations in Eastern Washington. Prior to that, I worked as a physical therapy assistant in Washington for over 10 years. And before that, I did health services in the U.S. Coast Guard. I had the opportunity to sponsor the first initiative that was drafted with the support of Whole Washington, and I've had the opportunity to participate in all the evolutions and updates and processes to get it where it is today.
Slide. So to just give a very brief introduction to Whole Washington, Whole Washington is a 501c4 nonprofit organization founded back in 2017 to really advance the issue of universal public health care at all levels, state, regional, federal. We're probably best known for the Washington Health Trust, which is a statewide proposal that we'll be talking about a lot today, which has been introduced in multiple iterations across both legislation and initiative. And a shout out to Senator Hasagawa for being the primary sponsor of every version of the Health Trust introduced in the state Senate. Slide. And to give a brief history of some of the healthcare stuff that's happened. This is really a lot of the more recent stuff, and we just include this to sort of acknowledge and visualize the way in which we've had our own journey at Whole Washington, starting with I-1600 back in 2018, the first time actually originally introduced as the Whole Washington Health Trust, introduced as an initiative to the people. But every year there has been significant progress made, whether that's us introducing it into the legislature multiple times where it has been improved and gone through additional review, but also important legislation done by the legislature or work done by this commission and similar groups like long-term care, Cascade Care, 5399, which formed this commission. And then actually a fair amount of playtime today will go to the capital gains tax passed in 2021, and then a recent Supreme Court ruling on that. So all of this is highly relevant to the design of universal healthcare. Also mentioned the 1332 waiver acquired in 2022, just to show that a lot of the work that needs to be done to achieve universal healthcare has been happening and can continue to happen. Next slide. So some goals for today, we kind of want to just start real basic with some, broad shared definitions of universal healthcare, set some outcomes and values there. And then the nuts and bolts of how the health trust actually works. We want to go into our proposed solutions to known barriers like ERISA and Medicare integration, and then hopefully get through all of this in time to give you some opportunity to ask us questions. Looking down the line, we really hope that this is the beginning of an ongoing and collaborative relationship with the Healthcare Commission. We think that a great way to continue this conversation would be actually a more detailed discussion with the Finance Technical Advisory Committee, because we've run some analyses on the costs and there's a lot of details there we won't get to today. But ultimately, we want to be co-developers of universal healthcare policy with the Commission that gets recommended to the legislature and passed so we can really start getting people healthcare. Next slide. So starting at the top with that definition, go ahead. We really like the World Health Organization's definition. So they say universal health coverage means that all people have access to the full range of quality health services they need when and where they need them without financial hardship. Identify some key elements of that, including universal eligibility, either automatically or through enrollment, a universal set of benefits, so we don't have a tiered system in which some people receive much better coverage than other people, uniform billing and reimbursement, which is a key component to making sure that the costs are shared equitably, and then significant public funding and nonprofit. Another way to think about this is really deprivatization, decommodification. I think those are some of the major differences between what we're proposing here and what we currently have. And one thing we like about this is just it provides a fair amount of flexibility. It identifies key outcomes, but is not highly prescriptive in the how. And that gives us the room to design a system that's going to be appropriate for Washington State in the current moment. Next slide. This slide, I think, speaks more to the values of it. So King County is named after that guy, Martin Luther King. What does he have to say about it? Of all the forms of inequality, injustice in health is the most shocking and inhuman because it often results in physical death. And that, for us, just keeps in focus the stakes here, the stakes of the action we take, but also the stakes of the action that we do not take. And that we're not just talking about cheaper healthcare or more convenient healthcare. We are really talking about a more just healthcare system and by extension, a more just society. And so we hope we can come up with something worthy of the namesake of King County. Next slide.
All right, so we wanted to also take a moment to kind of ground it in some of the work you guys have already been working on for a while. So this proposal is a bit of Model B and Model A hybrid that the models used for your guys are for the fiscal study. What we do want to say is it starts out as a Model B, but it's voluntary enrollment. So it's designed to grow a little slower than the model that you've studied. And it's designed to work towards Model A, recognizing that that's where the biggest savings is, but it may take time to do all the negotiations and processes required to integrate all these things.
So, going from outcomes and values and models, right, the next step we really see is policy. And so the Washington Health Trust is a universal healthcare policy. Next slide.
So the origins of different components of this proposal, honestly, the first section and healthcare coverage and the governance of the trust was originally inspired by the Washington Health Security Trust, which was developed by Healthcare for All Washington. And shout out to Marcus Riccelli, who was the sponsor for that several years in a row, or several legislative sessions in a row. The tax funding was guided by the study that we had done by Gerald Friedman, actually two, we had it updated when we made adjustments. He's an economics professor at the University of Amherst, Massachusetts at Amherst. Technical language was reviewed by Employment and Security Department and the Department of Revenue for the different funding mechanisms. And then a key set of provisions were collected into Section 101, and these were the core values consistently expressed by community organizations, providers, and individuals that they felt were really important that guide the trust.
So effectively, the healthcare policy is very, very complicated, as I'm sure everyone knows. But there's sort of three major pillars of what we're proposing here, right? And the first is the creation of public options such that anyone in Washington would be eligible to enroll in one. The second is the generation of the revenue necessary to maintain those public options, and we propose doing this entirely through public financing. And then the third is the creation / coordination of infrastructure to govern and maintain the system, and a lot of that is existing, others would be new. But it basically comes down to those three major goals. Next slide. To kind of put it into a little bit more of a step-by-step, what does the legislation actually do? The first thing is just the creation of the trust itself. So effectively a bank account, the revenues go in, the reimbursements go out. The second is the creation of the Washington Health Trust Board. That's the sort of key governing body of the Health Trust Board. A lot of this will come down to collaboration between the board and the healthcare authority, but a lot of authority is going to be given to those entities to design the specifics of this. And then we'll create some transitional plans, including a health options program and a Medicare Part C plan. And this is to provide some amount of transition for people who may be receiving coverage elsewhere or may be falling into a gap. We want to make sure that everyone is eligible to participate in this. And then the last is to establish the necessary funding, which will be collected and enforced through ESD and the Department of Revenue. Next slide. So we'll be diving into what all of this means, but trying to use the language of the commission as best as we can. We think it's a Model A-B hybrid. We think it begins with Model B, but over time transitions to Model A. And we say the Washington Health Trust is an all-payer model with a pay-to-play requirement for employers. It includes public options for all Washington residents, public health funding for participating community health providers, as well as the financing and transition plans necessary to achieve universal coverage. Next slide. So getting into the real specifics of how we achieve that, we want to go into the design components that were developed by the commission. So all of these categories should be familiar. We just added a little bit of additional detail on our transition plan, things that are fairly specific to our proposal and not necessarily permanent parts of the design. Next slide. So we'll start at the top with governance. Go ahead. And that's the Health Trust Board that we already mentioned. And in the most recent iteration of the Washington Health Trust, we actually added the Healthcare Commission, elevated the Healthcare Commission to be appointed to the board immediately. It is optional, of course, but every member of this Healthcare Commission would have the option to serve on this board. The board is also going to be expanded to include some new members. And then it's going to begin to create certain committees that will be collaborating and representing key stakeholders. So very critical, a citizen committee. We think this is an area where there could be more representation. But that committee is going to be publishing reports and holding public meetings to provide public accountability and oversight. There'll be a provider committee, and that will be facilitating a collective bargaining agreement with healthcare providers and negotiating reimbursement rates on service. And then last, a finance committee, which is going to be maintaining the revenues and managing the solvency of the trust. And we happen to believe that this looks quite similar to the FTAC that has already been formed. So in that sense, you can already see parts of this infrastructure have been coming into place over the last couple of years. And we want to just continue to build off of that into the system that we propose here. The board will be allocating funding to community health providers. And as we said, we'll be playing a very collaborative role with the healthcare authority, including on the acquisition of federal waivers. Next slide.
We identified another key responsibility and created some governance structures within the Healthcare Authority. The Healthcare Authority currently provides oversight and accountability to the insurers who administer our publicly funded benefits. So the HCA would also provide that same kind of accountability and oversight to the trust to make sure that they're meeting those goals. Again, this is in line with their current responsibilities. They also provide some structures and support for enrollment, just like they do now for other programs. They'd coordinate the integration efforts and lead all of the waiver processes. Waiver processes can be hard, complicated negotiations. They can be slow. So this bill is designed to leave room for that, but make sure that we're addressing the immediate needs of Washingtons who are underinsured or uninsured right now. And again, they work to acquire the federal waivers and will need the support of the trust in order to make that happen, provide the evidence, support, and infrastructure to show that we can successfully integrate those.
So getting into eligibility, and we want to keep it pretty simple. The big idea is that everyone would be eligible, right? So from the perspective of individuals, we base this on residency. We use the Washington State's definition of residency, which is 30 days. And so we completely define eligibility independently from the social determinants of health. So this is not based on age, income. If you live in Washington, you should be covered by this, or at least eligible to participate. And it's also going to provide eligibility for some non-residents, including students who might be going to school in Washington, workers who maybe are employed in Washington but don't live in Washington, and then in certain family situations, a spouse or a dependent might qualify as an eligible non-resident. Next slide. Similarly for employers, not required to participate, but no employer will be prohibited from participating. So all employers may choose to participate in this system, and they can do that for all of their employees or on a per employee basis. And there's going to be a required health spending expenditure per employee. And so basically that's the means of participating, is to pay that expenditure. And this is also completely independent on additional forms of coverage. So if they would like to provide employer-sponsored healthcare, if that employee has coverage from somewhere else, they are still 100% eligible to participate in the Washington Health Trust. Next slide. Benefits and services is more of the what's covered, right? In a universal system, it really should be all medically necessary care. And we define that in an essential benefits package. So hospital services, ambulatory, drugs, mental and behavioral health, lab work and tests, reproductive care, long-term care, pediatric care, dental, vision, hearing, rehabilitative services. All of this is defined in the essential health benefits package in legislation. Next slide. This is an area where the board will actually have a fair amount of authority. And so while this is the sort of required amount of essential benefits, the board has the ability to expand that package. The key component of this is that it is a single benefits package for all enrollees. This is not a tiered system. So if you're an enrollee, you're covered by this benefits package, and there is only one. And we're not going to have a system in which some enrollees are paying more or have better, paying more for better care. You know, from more of an aspirational standpoint, right, part of the idea here is that we're trying to set a standard that all state managed plans can meet, and that through the work of the Healthcare Authority, through the health options program that we're introducing, that we can kind of create a system in which on the back end, you might be covered by this program or that program. It's very complicated, right? But for the enrollee, you feel confident, I'm covered by the essential benefits package. It doesn't matter which state plan I'm enrolled in. So we want to set that standard and raise all state plans to that standard. Next slide. Providers, sorry, I'll pass this one to Erin.
So providers, essentially all providers would be eligible to accept reimbursement for any benefit that they provided to enrollees. They don't have to be contracted to or have a prior setup. That was just a key element of this. Those fee-for-service rates would be negotiated on an annual basis with providers' input and participation. So the idea here is that providers really want a voice, especially if there's going to be a single rate that we're trying to pursue, really want a voice in that negotiation process. In addition, it was important to them that they could not be denied reimbursement for benefits that they provide as long as it is within the line of standard of care. When you guys are starting to make out, do funding analysis, it's important to identify some baseline rates. Some assumptions can be made. So for our study, we actually made the assumption that providers wouldn't want to make less than they're currently making now for their total population of benefits. And so those rates vary quite a bit. But if you take and base it on population size and actually come down, it actually produces rates that are roughly 10 to 20% higher than Medicare rates are now. So I would suggest, starting by bringing in providers and also looking at those rates as they would be now. If all of them were the same, what would that total amount of funding look like, and average it out? Next slide. Aligned reimbursement rates are really, really important part of reducing the strain on providers. So the board would be responsible for facilitating negotiations that providers can participate in every year to negotiate fee-for-service rates. They would also offer opportunities for global budgeting type of rates in combination with fee-for-service if they're nonprofit and collaborating to expand capacity. Again, there's transitional rate alignment steps where the healthcare authority would use its authority to the degree it can to provide some reimbursement rate alignments across all the plans. Next slide. Global budgeting, we've had questions about this consistently, so we wanted to point out that global budgeting is designed to give the trust the ability to provide operational funding to nonprofits so that they can expand services. It's not necessarily designed to have the entire operational costs of an organization paid for or a health system, but it is able to do that if there was a region in huge need of services. Next slide. Cost containment.
Yeah, so sorry, I was going to take this one. So cost containment, I think starts with an acknowledgement that we have the most expensive healthcare system in the world. Our current total healthcare spending in Washington is about $80 billion per year. And we believe that we have a proposal, depending on exactly how you run the numbers, can save between 5 and 10 billion a year. We think that that's, our analysis sort of matches the healthcare work group's analysis in that sense. But in terms of the specifics of how cost containment would work, this is not something that we legislate in 5335, but we do give the responsibility and authority to the board. And so we expect the board to enact cost controls when necessary without limiting access to or reducing quality of care. There are many different means of cost containment that can be, looked at from other systems. But inherent to the design of 5335, we think are two key means of reducing complexity and eliminating waste, especially administrative waste. So the first is that we have a single essential benefits package, which means that it's not highly means tested. It's not, is this covered? Is that covered? The coverage there is very, very comprehensive and would be uniform for everybody. So much simpler in that sense. And then on the billing side of things, by having uniform rates of reimbursement, there's much less effort that has to be expended in terms of how much is this reimbursed for? Do we need to collect some of that from the patient? We actually, eliminate a lot of those all of those out-of-pocket expenditures and move that into public financing. So in that sense, we think we can save a lot on billing. And that's where most of that, the savings that we project comes from. Next slide. So going from costs into revenues, right? This shows the public financing that we propose. What's not on the slide is all the things that we're not paying. So, for enrollees of the trust, right? Premiums, copays, deductibles, out-of-pocket expenses, all of those things are eliminated and replaced with these forms of public financing, right? So the first is an employer tax of 10.5%. That's per employee, and it's based on payroll. So on the pay for that employee. We'll go into more detail about this in a moment, but this 10.5% is actually going to be required whether you're paying into the health trust or whether you are paying into other forms of healthcare for employees. But we'll just say that compared to what it costs to provide healthcare coverage for a workforce anyway, this is really quite competitive. It is not uncommon for an employer to be paying 12%, 15% or higher to provide healthcare to their workforce. That might not even include part-time, contract. Lots of people are working there. And one nice thing about participating in this system is it completely relieves the administrative burden associated with providing that coverage. So no more, admin, no more shopping for plans. This 10.5% would simply be paid, and then the employees are now eligible for enrollment. So that's the employer tax. There's a 2% employee payroll tax, and this is actually a way that cost is shared between employer and employee. So we'll show this visually in a moment, but that 2% actually subtracts from the 10.5%. It does not add to it. So it's a 2% deduction from employee payroll. And again, compared to monthly premiums, this might be pretty competitive compared to what an employee might be paying. But it's it completely eliminates the surprise out-of-pocket expenses, right? When you go to get care, you know that you just go in and receive the care. You're not thinking about cost anymore. That 2% also applies to sole proprietors. And then the last one is an 8.5% capital gains tax. And this was something included to allow us to create a progressive funding structure within Washington State's tax code, which can be quite difficult to work with. And so our analysis shows that about 90% of Washington State makes less than $10,000 a year in capital gains and really would not be affected by this at all. But another little point we want to make here is that this funding structure was designed before the passage of the capital gains tax, and especially before the recent Supreme Court ruling on it, which in our opinion changes precedent a little bit. We've always wanted to exempt people who have the most need for care and the least ability to pay for it from as many of these financial contributions as possible. And that's difficult in our tax code, but we believe that there might be more room for exemption at the bottom than previously thought. And this is something where we're very open to collaboration and revisiting what's proposed here. But we do think it raises the necessary revenue. Next slide. So this just shows that sharing between employer and employee, 10.5% on for employers. That's a required healthcare spending. And then they may deduct up to 2% of that from employee payroll. Next slide. So to see how that breaks down visually, and in this we're assuming that employers fully put that 2% on employees. They may actually cover any or all of that 2% as a benefit of employment. But assuming that they're paying only 8.5%, you see the light blue segment there is about 3/4 of the funding. The employee payroll then is that section in the middle, and then a relatively small sliver for capital gains. And the more employers who choose to cover that 2% employee payroll deduction, the more of it would be light blue, like you see in that first chunk. Next slide.
So to create a little more context, especially since we use a graduated exemption for this 10.5% required employer expenditures, that graduated exemption is quarterly. So we put this in annual numbers, but depending on like what part of the year an employee, this is making the assumption they work the same amount all 4 quarters of the year. So again, for lower income or lower paid, this was like nannies. This would be folks that are working very part-time, under 12,000 would not have any required health expenditures by those employers. As you move up the scale, 20,000 to 60,000, a lot of our employees are in this range, especially the ones that don't have coverage currently. And you can see that we're talking about $87 a month, ranging up to about $525 a month. Again, this employer would be required to spend this amount towards the employee's healthcare in a variety of ways, but it's also the amount that they could spend to enroll them in the trust. And then you can see that it's even competitive as you move up the income scale. And we'll go ahead and move to the next slide and create a little context, just a refresher about where we are now. Currently, the average employee earns about $57,000 a year. So again, right around that middle mark. The average employee pays monthly $475 for an individual plan and over $1,000 for a family plan. The average cost, the employer-sponsored coverage insurance annual premiums was around $7,700, and for family coverage, it's around $22,000 a year. So under our proposal, we plan on covering kids across the state without any kind of cost to the families. So right away, there would be a benefit to employers who have a large number of families, employees with large families, because there's a really big difference between that number. And then on top of all of that, the average employee pays an additional $1,600 in co-pays, deductible, and other costs that throughout the year to actually get care. Next slide. So we're going to talk about infrastructure. The basic infrastructure that is building on existing structures, with the exception of the board, although again, we suggest using this existing entity to sort of start that process. The board would be acting as an insurer, a managed care organization. And in that way, it would contract with the healthcare authority. Healthcare authority would provide, as it does now, oversight and accountability, enrollment support, and infrastructure. They would also be coordinating those efforts for waivers. The governor and the legislature support this effort by providing startup costs and also reviewing those reports from the HCA and the new trust board and making policy changes as recommended. The Employment Security Department would enforce the required healthcare expenditures and facilitate participation for those employers who want their employees to participate in the trust. As a way to meet that spending requirement. And the Department of Revenue enforces the capital gains tax as it does now. For enrollment, enrollment processes are not detailed in this proposal, and part of that is recognizing that those processes might evolve over time as those integration processes happen and we are able to integrate plans. We can make it more smooth. So initially it's enrollment would be managed by the healthcare authorities so that those who are eligible for Medicaid and Medicare can be enrolled in the right way and our state can receive the funding it needs for those enrollees. It would use the existing infrastructure like the Washington Healthcare Health Plan Finder, again, to meet residents where they currently are in their enrollment processes. And then it would have the ability over time to evolve them. Again, the Employment Security Department is given this role to support businesses, especially small businesses, to transition into a health spending requirement. And with a new requirement in general, this is in line with their current duties for the WHT CARES Act and for other programs that we have. Small businesses can also get cost assistance from them if they face financial hardship as we roll into this program. Next slide. So working within ERISA, much like was pointed out earlier today, there are some opportunities to bring in line and align spending in the employer market without requiring them to participate. So we can require that they cover their employees, all of them, not just the ones that the Affordable Care Act requires. We can require employers to spend. I'm so sorry. I'm so sorry. So we can require them to spend a certain amount, and we can define what that spending is. We can also cover all kids. In Pennsylvania, I believe in Pennsylvania, they are using a program to actually cover all kids are eligible to enroll in CHIP. We can create a framework to provide health coverage and cost equity to employees that are not enrolled in the trust, i.e. supplement their employer's coverage if they are willing to participate. And we can work to bring in line, continue to work at looking for new opportunities to integrate employer spending. Next slide.
I just want to add, sorry, just want to say that we designed this plan after the model developed by Healthy San Francisco. So that's a city option plan. It has survived legal challenges on the basis of ERISA. And so we are highly confident in the legality of the design that we propose here to provide this coverage, to include employers without running afoul of ERISA challenge.
Again, just to clarify that the spending requirement is not an obligation to participate in the trust. And even when they're not participating in the trust, if they choose to spend towards their employees' healthcare in another way, they are still contributing to that employee's healthcare. Those options include continuing an employer-sponsored coverage plan for them, direct employee healthcare covering, so covering someone's actual costs or contributing to a health savings account to cover the costs. And it also would include the WHT CARES Act. Perhaps they want to use a private insurance option, but they would additionally meet their obligation by adding that long-term care coverage. Transitionally, we're going to talk about just a couple of transitions. The health options plan is a transitional plan that would be managed by the healthcare authority. It's designed to support the uninsured and the underinsured. It builds on their existing programs to support people who aren't sure how to navigate their health insurance coverage. And it would evaluate and look for any kind of discrepancies or inequities by providing that assistance through a side program that they manage. They can use this to monitor changes in enrollment, to provide oversight and feedback on the process. And long-term, this can also support enrollment in the trust. Medicare integration waivers, just to put it in framework, this one is really looking at having the healthcare authority try to pursue a demonstration waiver, recognizing that that might be a difficult battle and requires some infrastructure to be established first. It does instruct the healthcare or the new trust to go ahead and create a Medicare Advantage plan and offer it to the state, those who are eligible to enroll in Medicare. It also leaves some room for the health options program to provide gap coverage for those who are not enrolled in the trust for coverage. Next slide. The healthcare exchange is one of the few that we call out in a unique way in the proposal. We recommend that the funding that's being provided federally for cost assistance on the exchange be phased out and directed towards the trust directly once our state has more than 51% of its residents enrolled in some publicly funded health plan. So that could be the trust, or it could be traditional Medicaid, or it could be traditional Medicare, but it's a publicly funded that could be one of the dual eligible programs for Medicare, but one of the state managed plans. That we should direct that funding directly to the trust, and it would be the only plan available with cost assistance. It does stipulate that the health benefits exchange structure can remain with the healthcare authority and continue to be used as a supplemental structure, either for enrollment or whatever else work that needs to be done and to keep this a sound system. Next slide. This is our transition plan, and it's basically a 5-year rollout of first becoming established and getting that initial funding from the capital gains, helping employers to prepare for the process of required health spending, which actually wouldn't happen till year 4. And so it's like a 3-year rollout. The first 2 is preparing to enroll all of those who have the immediate need, the uninsured, the underinsured who have immediate need, and voluntarily enroll. And then there would be those incentives for employers to contribute towards their employees that aren't currently covered, or who they're not providing enough cost assistance for that coverage, where they could choose to enroll them in the trust. At year 5, we stipulate that the amount that is required, the required healthcare spending by employers, should be reassessed, and the Employment Security Department can adjust that rate if the rate is. We know that there is administrative savings in reducing the administrative burden on providers. So the goal is ultimately, if there is too much funding for this trust or this process, then you can adjust that rate for providers and do it in a uniform and equitable way. But we do want to make sure that the trust has the funding it needs when it first gets started, and maybe primarily enrolling the lower income residents who are on the lower mid scale.
Okay, so it's a lot of different moving parts there, but to go back to that in a nutshell, like we said at the beginning, the Washington Health Trust is an all-payer model with a pay-to-play requirement for employers. It includes public options for everyone, public health funding for participating community health providers, as well as the financing and transition plans necessary to achieve universal coverage. That's using technical language, it's descriptive, it's the language of the commission. We might phrase it a slightly different way. So for us, the Washington Health Trust establishes a single benefits package and a public option that can immediately begin to offer everyone coverage. It outlines a framework and a transition plan through voluntary enrollment, employer participation, and integration of state and federal programs which can achieve universal single-payer healthcare. So importantly, this gives us the means to take those first steps to begin to create the framework for universal healthcare, but it will not be universal on day one, will not be single payer on day one, but it is 100% achievable. Next slide. We just want to end with some optimism here. Washington State can do this. We lead best with our example. We've done it on so many issues, whether that be drug decriminalization or marriage equality or reproductive rights. Washington has always led federal politics on this. And we know that it can be done on healthcare because it's been done before. So on the left, we have Canada, and the province highlighted there is Saskatchewan. That was the first province to pass universal single payer in Canada. It is not a liberal province. It is not an urban province, but it is a province full of people that needed healthcare. And that movement carried it through to establish the universal healthcare system of Canada. On the right, you have the United States, and much debate goes to whether this can be done at state level or if it should be federal first or what have you. But we highlight the state of Massachusetts to remind us that the last major reform at the federal level to our healthcare system came from the state of Massachusetts. And we hope that the next major reform to our healthcare system might take inspiration from a highly functioning universal single payer system that we develop here in Washington State and put on the table for the rest of this country so everyone else can get healthcare as well. And we don't really think it's important if you call it Cascade Care for All or Universal Apple Health, or statewide Medicare for All. The important thing is that it establishes that universal eligibility, that comprehensive essential health benefits package, and really starts to get people healthcare who have not been able to get it before or who have been, just completely burdened by the costs associated with it. So with that, we are so grateful to have gotten the chance to present today. And with whatever time we have left, we'd love to answer your questions.
Thank you, Andre and Erin. We've got about 4 minutes. Are there any questions?
So this is Jane. I just want to be sure I understand the pay or play component of this. It sounds like, in essence, there's a minimum monthly contribution that's based upon the employer's revenue, and that minimum can be met via either an employer's maintaining their plan or modifying their plan however they want, but whatever the value of that is, or, and you've got, contributing funds into a health savings account or CARES, and then whatever's left over, that's the obligation that they would have to the fund, or am I not catching that correctly?
I think the first thing that I wanted to clarify is that the amount the employer is required to pay is per employee. And it's designed to ensure that they are contributing towards each employee's care, even if it's part-time, even if it's contract. And it's graduated in that way to make that a reasonable cost for an employee who might be temporary or might be contract, might work a very limited number of hours. It's designed to ensure that they're contributing towards each employee. They can spend it in a variety of ways, but for the vast majority of those employees, being able to enroll in this program is the most cost-effective option. Now, we know that there's a lot of employees that already have coverage that they are very comfortable with, and they're hesitant to leave that. And so, at least initially, employers could meet that health spending requirement by continuing that coverage, but it's a specific amount they're required to spend on each employee based on that employee's pay.
Thanks.
Representative Schmick.
Thank you. I got a lot of questions, but I'm just going to ask one. And how are you going to deal with a lot of people who do not trust the government and really are going to be reluctant to want them to put the government in charge of their health care? How would you go about addressing that? Thank you.
I think the first component of it is that this is a very voluntary model, right? From both an individual and employer standpoint. And so in that sense, if people are hesitant, that might be something that they consider over a number of years to see how well it's working. But the other thing is that people don't necessarily always have great feelings about the government or taxes. This is very common stuff, but people also don't have great feelings about their health insurer a lot of the times. So people are very, very burdened by our healthcare system. They have to pay a lot. They are shocked all the time to find that things aren't covered. And then they get, buried in paperwork and put on hold. So I think that, compared to what people are dealing with, we can definitely offer something that provides a better experience.
Yeah, and I would just like to add to that this proposal recognizes that it will take time for people to, for everyone, to be confident, especially those who have been burned by this health system in the past. So I think it's really important to recognize that's why it's voluntary, which is it's designed to give you time to build that trust. You build the trust, and you that's how you deal with those issues. You can't force people who have never experienced this type of quality government program to trust it. You have to show it to them have friends and people in their community that are getting that benefit. You have to allow employers to see and compare it to what they're currently offering. I think that's the key. You have to build something and be reliable.
Thank you. Mohammed, and then we're going to move on.
Thank you very much. My question is, first of all, this is really impressive and a very good presentation. I have a question opposite to what this representative just asked. How soon, what is the soonest that this can roll out? Because there's a lot of people that's hurting by the, the existing insurances right now, including myself. I literally have been paying half of my salary to get premiums for my family and myself. That should be illegal, in Washington, anyway, in America. Is there so basically when we talk about health and the needs for healthcare, it might not have a lot of time to it. There are people who are, in pain right now or would like to get healthcare right now that cannot afford or do not have. So they might not have, years to wait. Is there, what is the fastest this can start covering all of Washingtonians? And is there a more quicker option for people that might be in bad shape because of the existing failing healthcare system or health insurance? Thank you. I don't want to take a lot of time, but please tell me if those questions do not make sense or if I need to repeat them.
No, I think I understand. This does make the assumption that it might take a couple of years for the trust to get established. So it has year one, focusing on establishing those benefits and reimbursements and the budget, and year two, getting those contracts in place so they can start enrolling folks. So the idea is that in November of the second year, so in line with current enrollment processes, meeting folks where they are, is when you'd be able to start. In truth, though, there's a lot of flexibility in this design, in that ultimately it could be kicked off sooner if the board of the trust is able to get those things accomplished sooner, and if the healthcare authority is able to get their responsibilities set up sooner. So in that sense, what can we do sooner than that 2-year mark is really up to the entities that take it over.
I'd just like to add, I have not seen a proposal that kind of proposes a faster, more immediate rollout. The first version of this trust was introduced into the Senate in 2019. That was a few years ago. And I think it's important to reflect on really the fastest way that this can happen is for immediate action to be taken to pass this or parts of this, some form of this. The Health Security Act, that kind of predates this, goes back even considerably further. But the point here is just that, yes, it takes a while to fully realize the systems that we're proposing, but the critical steps are committing to that process and saying, we're going to establish universal health care, and we are going to begin as soon as possible. And so, we think that the formation of this commission is a great step, but we want to also just keep in mind that, the real enacting of policy is still ahead of us. And that's something that we should not delay on as much as we can.
Thank you. Thank you for this great presentation, Andre and Erin. I'm sure there's more questions.
All right, guys. So I think we already have a few questions. I saw Lori's hand go up first, so I think I'm going to let her go first. And then we have some from the YouTube showing too, it looks like. Go ahead, Lori Fleming. What's your question?
Okay, so say if my employer does not want to participate in this plan, will I be suffering more from, further lack of coverage or higher out-of-pocket expenses, or would they have to meet the standards that you put in place? You follow what I'm saying?
Mm-hmm. I'm not sure who wants to answer that. I thought I'd give Carrie a chance. Do you want to, or if you don't feel comfortable, I can. And just so everybody knows, this Carrie Wallace is our new our new chair of Whole Washington. So welcome to Carrie. She's been an awesome volunteer.
Yeah, thanks, Catherine. And I think that question might be beyond my expertise at this moment, if you want to take it.
Sure, I will. So the interesting thing about that is if your employer can opt out, but he still has to provide coverage for, he still has to provide health insurance coverage for you, right? based on what he pays you in your salary. Now he can provide it in another through a different company, but it might not have as good, it could maybe not have as good of benefits. The trust doesn't require that those benefits are the same, but now I can't remember what it's called, but they're referred to another program in there, the Healthy Options Plan. So for people whose companies maybe they decide to keep because of they decide to keep their plan, they want to stay with the company owners want to stay with who they're using, or they have like a union protected plan, they want to stay with that. Those people can use the Healthy Options Plan so that they would then have the same benefits of anybody who's on the trust. So they then have no copays, no deductibles, other than maybe $250 a year if you choose to have a prescription medication when there's a generic available. But basically that way you have the same benefits as everybody else in the state. So part of the funding goes into that Healthy Options Plan to give those people who are uninsured or underinsured the ability to have the same benefits as everybody.
So, Catherine, they'd essentially be enrolled in both?
Yes. Yes. Okay. During the transition, I think. Well, no, because the thing about ERISA, yeah, it would be like until the employer chose to. The thing is, the employer has to make those contributions somewhere to your health care. Now, the interesting thing is that, like, I looked at it, I work for a relatively small hospital system, and I was like, where's this money going to come from? Where is the savings going to come from? I don't get it, because I look at the rates, and like for what I make for my income, what the trust collects is about what my employer is paying and what I'm paying. It's about the same. Is for those people who don't make as much money, that are in that more 50 to 60,000 range, that's where the most cost saving is for the employees. But when you look at my company and where I have a CEO who is, I think he's well paid, but he's not near as well paid as some of the other CEOs in the state of Washington. He makes $1.6 million every year. Okay. My company, my hospital is not paying $101,000 or $160,000 a year for his health care. So for that person, they're going to have to pay for a whole lot more. And, it's like, oh, my company's not going to save any money. But I kind of think to myself, realistically, they can still make the numbers come out because they can just reduce this amount of pay. If they reduce it by $160,000, if he can't cut, I'm sorry, if you can't figure out how to live on $1.4 million, maybe you need to go back to school on household budgeting. So anyway, okay, more questions. There's some questions on YouTube. Let's address some of those real quick. And I think we actually might have addressed okay. One was really good. Okay, so aside from the proposed capital gains tax, what differences does the Washington Health proposal have from the existing Cascade Care public option? The thing about the public option, the nicer thing, why it's better than Cascade Care, is that all of the providers, the hospitals and the doctors and the clinics would be able to negotiate the rates of reimbursement. The difficulties with and also anybody would be able to enroll in the trust through the public option, okay, during the transition period. Right now, the way Cascade Care is, you have to not be able to, in the state's mind, feel that you can't afford anything that's available right now currently on the, what's it called? What is that? I've never had to use it. The exchange, right? The exchange. So you can't enroll in it just if you want to enroll it. You have to be at the lowest of income levels, and I think there's a few more people that have been added at the very first year. There was only 1,800 people that were in the Cascade Care. The other bad thing about Cascade Care is you have Medicare reimbursement. Medicaid reimbursement runs about 60% of Medicare. Some of the outpatient things are a little bit higher than that. Cascade Care is 40% of Medicaid reimbursements. So after it was first enacted, the hospital said, no, we're not going to take it. We can't afford to deliver care for that. So the next year, the legislature went through and passed another law and said that if a hospital system has more than four different areas, 4 hospitals, 4 clinics, whatever, they have to accept it. So, that's not really fair to the providers either, to force them to accept. So how do they make up that difference? The people who have private health insurance pay a whole lot more to cover all of those expenses. Okay. Let's see. Oh yeah, healthcare. Okay. Somebody else thing. Then the other question on YouTube, which I think is a good one too, is there anything in the Washington Health Trust that addresses cost control? For example, a hospital charging $50 for a gauze. And that kind of relates to what I just said. The reason they charge $50 for a gauze is to help pay for all those unreimbursed expenses. So if we start, the thing that it does do is it allows for global hospital budgeting so that the hospitals can look at, this is what our true cost is of providing care. And so there will be a budget for that hospital. This is what it costs us every year to keep our doors open. For a lot of hospitals, there'll be some hospitals in Eastern Washington where they may not really provide or bring in the income. And so there's not enough profit for the profiteers. So they shut it down, but those services are needed in those areas. So sometimes there's going to be a hospital that maybe doesn't bring in as much income to cover all of its expenses, but the trust will cover it through a global hospital budget. Okay, any more? Do we have any more questions online or in the room here? What'd you guys think? If anybody wants to speak up and tell me what you think? Go ahead, Dave.
Yeah, I thought it was really good. The Andre and Erin, split it up well and sounded really professional. So, I don't have a whole lot of hope, but that's not Andre or Erin's fault. We just have to see what the report is and if the legislature feels like doing anything about it.
Yeah, I agree. I thought they did an awesome job. I personally, I agree with you, Dave. I don't think it'll help. Maybe, I hope so. I really hope so, because it would just be awesome. And that's why we need to keep up working, developing plans to run another initiative. Because then if we get an initiative, we get it on the ballot, the people vote for it, they have to do it. They can't, just decide that they don't want.
I think it helps us more than anything else. I think having this presentation and having the plan and the vision clearly articulated and on file helps us with the educating the public and then pushing for, collaboration around a future initiative from other healthcare organizations and other organizations that are interested in collaborating. So yeah,
for sure. Yeah, great. And yeah, it'll be great to be able to take this presentation to our elected representatives and senators. I saw that Alice, hey Alice, great to see you. She's got a question. Oh, there she is.
Great presentation and really helpful for new volunteers to get all the nuts and bolts in a row. And Andre is such a great presenter, and Erin is so good with with the facts and figures and really breaking it down so it makes sense. It was a really good combination of how they presented it together. So I would like to see this in the toolbox for training, on the initiative for people who are gathering signatures, because when you're out there and you're just trying to get those signatures, you do get the stumpers of, well, wait a minute, so it's great. I love to see it. Thank you. Thanks for sharing it.
Welcome. And I really loved how they addressed the whole what about people who don't trust our government? I thought they had great answers for that. It's like, well, we're gonna have to make sure we make it something that's trustworthy, and it'll just take time to develop trust. But you can also look at the stats we don't have any countries that have gone to single payer universal healthcare plans that have decided, oh, we can't do this. Let's go back to what we had. Anybody else? Well, I want to just encourage, oh, go ahead.
It was the second time I saw it. I just thought it was really good again. That's all.
Yeah, it was. They did they did an awesome job. So I want to encourage everybody, if you can, at 7 o'clock is our volunteers meeting. Feel free to join us for that. It's a different link, but you can get to it from our website. I probably should have had it handy and posted it in the chat, but you can get to it from the website and register for that. It's at 7. Usually lasts about an hour 15 minutes. Okay, we'd love to see you there. And we really appreciate you showing up and for all your questions. All right.
We can't sign off without plugging the donate link. I just put in the chat.
Okay. And also, if you're going to be at the fair, we're going to be the Puyallup Fair the last 3 days of September. No, the last 3 days of their weekend. So it's like the 22nd, 23rd, and 24th of September in the expo hall underneath the grandstand. And the theme for that area on that weekend is going to be community or consumer awareness, which is going to be awesome. So if you'd like to hang out and get a free ticket to the fair, check out the fair channel on Slack and join us and sit, and we're going to just have a whole lot of fun at the fair. All right, guys. I'm going to stop recording, okay?
Recording stopped.